6 weeks ago, complicated by post-op wound infection and treated with IV Vanco. His prosthesis was removed 2 weeks prior, and isolates from his wound have included MRSE, Proteus vulgaris, and E. coli. His current medications include sliding scale insulin, hydromorphine PCA for analgesia, and daptomycin, on which he was placed following the removal of his prosthesis. A resting room air O2 sat was 71%, which increased to 89% on 6 liters O2. Chest imaging was obtained as below, and you see some pleural effusions, bilateral opacities. And so the question really is, which of the following best characterizes a lung injury pneumonia associated with daptomycin? And I'll let you guys think about it and talk about it. But again, they could have also asked which medication is related to the lung injury, what type of lung injury do we see? And this really goes into some of the difficulties of drug-induced lung diseases, in that some of the things you just have to know. You have to know what meds are associated with lung disease and what type of lung disease, if there's a specific one. And also, this is something that's ever changing, right? Because we don't have all the data of post effects on medications when they come out of clinical trials. It's only once they start getting used that we start to notice some of these things as we'll go on. So I don't know if anyone wants to give a guess or not, but
Samir, the answer, well, is it D?
So it is not. So it is not B. And actually,
D as in dog.
Oh, D as in dog. It is not D, although we don't like daptomycin for the lung for this reason. But what they're trying to get at with the previous CAT scan, the infiltrates, the acute hypoxemic respiratory failure, and daptomycin is the fact that daptomycin is actually one of the common medications that causes an acute eosinophilic pneumonia. And so these slides are here in case anyone wants to review this later, or you can also find these on Seek. But a couple medications that are really prone to causing acute eosinophilic pneumonias that you should know are daptomycin and minocycline. Daptomycin is one we use a little bit more commonly, so one that seems to be tested a little bit more. But again, taking into account all the stuff that you know and all the things that you're going to learn in the lectures that are coming up, particularly with eosinophilic lung diseases here, that you see bilateral effusions in up to 70% of patients with AEP. They may have also given you BAL data that showed an elevated eosinophil percent, which would differentiate it from chronic eosinophilic pneumonia. But really sort of recognizing that daptomycin can cause a type of respiratory failure. And, they further go on to suggest that AEP may be an acute hypersensitivity reaction. And it's also associated with exposure to other things such as tobacco smoke, dust exposure, military exposures, and such. So something that we have to be on the lookout for. Again, as I say, daptomycin is the most common antibiotic associated with AEP, but also minocycline is one that we see as well. So, just keeping in mind, and also, partially biased that this is a talk about drug-induced lung diseases, that we may gear our answers that way. But, we always have to keep in mind that some of the drugs that we give our patients, even if they're not intended for the lungs, may have consequences. And so then they go into a little bit about the diagnostic criteria for drug-induced eosinophilic pneumonias. And I believe this will probably get touched on in your eosinophilic lung disease talk as well. But it's something that has no alternative etiology. You have a BAL with an elevated eosinophil percent, and really discontinuation of the offending agent is the hallmark of therapy, and then plus minus steroids. In this case, if you see acute eosinophilic pneumonia with daptomycin, you are discouraged from re-challenging patients. Again, not something that we're want to do. And then just some references if you want to look this up later. So really, to take a step back, and we'll look at drug-induced pulmonary disease, and that's really defined as any lung disease that's caused by a drug or a medication. Drug-induced interstitial lung disease, or DI-ILD, is actually a recognized subtype of diffuse parenchymal lung diseases in the ATS-ERS classifications. It's enough of an idiopathic or interstitial pneumonia that it has its own categorization, and it can occur when exposure to a drug causes inflammation and eventually fibrosis of the interstitium. There's over 350 drugs that are known to cause DI-ILD. and I believe over 1,300 medications that are known to cause some sort of pulmonary disease. And we're going to differentiate those out in a little bit. This is a diagnosis of exclusion, and sort of a lot of the clinical talks we've had lately, we want to rule out infections, you want to rule out other things, malignancy and such. But there are no really hallmark clinical, pathologic, or radiologic features that can guarantee that this is going to be your diagnosis, or really differentiate from other interstitial pneumonias, other than thinking about it, stopping the drug, and then potentially giving steroids. So drug-induced pulmonary diseases can be broken up into a lot of things, right? You can have drugs that affect the airway, so things that cause wheezing and bronchospasm, things that affect the interstitium that can cause ILDs or pulmonary eosinophilias, like we'll see, and then things that can affect the pleura, so pleural effusions and such, or things that sort of go along with vasculitis. So not all of these are hallmarks of DI-ILDs, but again, they're things that we should be aware of, and things that you may come across. The Murray and Nadell chapter for this is quite exhaustive, but it goes through a lot of different medications. So if you're interested in a particular medication, whether it be bleomycin or mitomycin or different chemotherapy agents, and understanding the mechanism of those for what we know, that's a good chapter to refer to. But overall, the chapter is probably not your best source of information, because things change so much. And we'll touch on some medications that are not mentioned in recent review articles, not mentioned in the chapter itself, that are probably going to be the most important for your boards as those come along. So another question, a 66-year-old man with a history of Hodgkin's lymphoma treated with chemotherapy, last given about a month ago with progressive dyspnea. He reports rapid worsening of his dyspnea with associated dry cough, chest pain, and a fever of 38.8. He has received 4 rounds of chemotherapy, which consisted of doxorubicin, vinblastine, dacarbazine, and bleomycin. He denies sick contacts, and there is no travel history. All other findings on review systems are normal. His home medications include prednisone 50, Bactrim prophylaxis, and Protonix. On exam, he is afebrile, in respiratory distress, and crackles are heard bilaterally. His O2 levels are 89% on 4 liters via nasal cannula. CBC count and chemistry results are normal, as are RBP findings. Antibiotics are begun. He is admitted to the ICU, rapidly decompensates despite 100% oxygen, and is intubated. Representative chest CT images are seen, a lung biopsy is performed, and the results show focal type 2 pneumocyte hyperplasia with intraalveolar fibrin. So they're going to want to know, what is the most likely diagnosis? So I'll let you guys take a minute to look at these. Are the CAT scan pictures in a young gentleman with who just underwent chemotherapy.
Is it B?
Bleomycin?
It is. Very good. So, right, they're trying to get you down the line of understanding whether either this is bleomycin toxicity. Obviously, pneumocystis is in the differential, but this is someone that was on prophylaxis, so that becomes a little bit less common. And then, obviously, things like multilobar pneumonia and lymphoma. And while we do see lymphoma in the lungs from time to time, he's been on therapy, so to have an acute worsening related to that is unlikely. Bleomycin is another drug that's going to be commonly tested. It's one that we see a lot, and particularly in young patients with Hodgkin's lymphoma. You'll see it even in your clinical practice, where they're sent for PFTs as their oncologists decide whether or not to use bleomycin as part of their treatment. So again, as they answer this question, this is bleomycin-induced lung injury, and this can develop anytime between 1 and 6 months after bleomycin is started. The symptoms are really nonspecific: cough, some pleuritic chest pain, fevers. And while we don't fully understand the mechanism, it is worsened in the setting of a high oxygen requirements. So really, I think that they're showing you he goes to 100% oxygenation and has worsening. It is probably related to some of the oxidative damage, the free radical species that are there as this progresses. It also gets worse in the setting of radiation, apparently. But, looking at bleomycin itself, as he was on his 4th cycle, patients actually have an increased risk with the cumulative doses of bleomycin. And we'll talk about it a little bit later about whether prevention or screening is really necessary or warranted. And I sort of always have Seth Koenig in the back of my head saying, if this chemotherapy is going to save somebody, then who really cares what the PFTs show? But you have to understand what you're looking at and how much this therapy is needed. And I think a lot of the times these issues we see in our chemotherapeutics create a difficult problem, because we have to balance the risk benefit related to lung disease from chemotherapy agents to the potential curative intent, right? So if they're aiming for cure, then that may be more important, and we may tolerate a little bit more abnormalities in pulmonary function. But if the treatment is not meant to be curative and maybe palliative or delay progression, then maybe that's something that we have to consider a little bit more. And then the other thing they want to pull out is that biopsies in these bleomycin patients will often show focal type 2 pneumocyte hyperplasia with intraalveolar fibrin, just a clue. But again, there's no pathologic hallmark, unfortunately. So just a little bit of background of this and why we care. Adverse drug reactions are a top safety priority. Obviously, we don't want to make mistakes, but also some of the medicines we give people have unintended consequences. In 1999, the Institute of Medicine reported that medical errors, including medication errors, are responsible for 98,000 patient deaths per year. Medication errors or medications injure 1.5 million people and cost billions of dollars. So again, something that the government took seriously, and as government organizations take seriously, they impress upon us to take seriously. And it's important. We should know what we're doing to our patients. It's estimated that less than 5% of all adverse drug-induced pulmonary diseases and overall less than 1% of serious unexpected events are actually formally reported to the FDA. So the totals are maybe much larger. And then again, more than 1,300 drugs have been identified to cause adverse pulmonary reactions. And one of the best sites I've seen and was first introduced to me by Dr. Singas is Pneumotox. You can go on and find any of these medications, and it's pretty regularly updated with different patterns of disease, because we first start seeing this in case reports and case series, and then sort of it gets to FDA warnings and things like that. So it really helps you if you're not sure if a disease is causing lung damage, whether it's been reported before or not, and more than likely it has been. This is not something for you to remember, but the Merck manual has broken it up like this. There are things that cause asthma, which is a little bit separate, but then organizing pneumonias, hypersensitivity pneumonitis, interstitial pneumonias, and fibrosis. There are things that cause non-cardiogenic pulmonary edema, including Narcan or naloxone, which we had talked about, I think, at a radiology conference by Andrew on Monday. Things that cause parenchymal hemorrhage, pleural effusions, pulmonary infiltrates. And you'll see a lot of crossover. There's a lot of medicines that show up in 1, 2, or 3 of these columns because they can cause many different histopathological issues. Previously, fen-phen or fenfluramine was a big test question because that was an appetite suppressant linked strongly to pulmonary hypertension. It's now been banned by the FDA, so probably not one that you'll see quite as often, but again, something that you should know. As you look at this list of diagnoses and some that cause organizing pneumonia or interstitial pneumonias, these are also the differential diagnosis for anyone that comes in with these abnormal CAT scans and hypoxia, right? We look at the CAT scans and say, well, it could be anything. It could be blood, pus, water, malignant cells, or something else. And this is where we spend the majority of our time making our clinical decision making. This is sort of what our case conferences have been over the last few weeks, trying to decide, should someone be bronched? Should they not be bronched? What other testing do we need to try and figure this out? And this is really where we make our money as we start to analyze these things and use our brains to be doctors to try and help people. Asthma is the most common drug-induced pulmonary adverse event. Its clinical presentation is asthma, so it doesn't need much more definition than that. And it's worse in people with pre-existing reactive airway disease, smoking, advanced stage. There's a number of different medications that cause asthma-like symptoms, and they're thought to have different mechanisms. So cephalosporins are thought to have an anaphylaxis, which is IgE-mediated. Cromolyn, NAC, inhaled steroids may cause some direct airway irritation, which is interesting because inhaled steroids are part of our asthma treatment. Aspirin is a cyclooxygenase inhibition, and then adrenergic receptor blockers can cause a pharmacologic effect. But again, there's a lot that you can dig down into this. It's probably not as relevant for your board studying, but good to know and important as you get people that have maybe an extremis in how to treat them. What really this talk is about is this. It's drug-induced interstitial lung diseases. So, and really that incorporates these idiopathic interstitial pneumonias, pulmonary fibrosis, organizing pneumonia, hypersensitivity pneumonitis, and then organizing pneumonias or bronchiolitis obliterans organizing pneumonia. The exam is benign. It's sort of like a lot of our people. Fever is common, but not always. Chills, some weight loss, some nonspecific crackles. Imaging is nonspecific, but it'll show a diffuse mixed alveolar interstitial pattern, sort of our B lines with probably irregular pleural and an ultrasound. There may or may not be pleural effusions. PFTs, which we'll touch on again a little bit later, are usually abnormal. DLCO often decreases before your lung volume reduction. So a reduction in DLCO may be seen in a pre-symptomatic patient and maybe one of your first clues. Bronchoscopy with BAL, we can go back and forth about doing it, but it's probably best in the presence to exclude infections or other causes, and not really going to give you a diagnosis for drug-induced lung disease, but useful nonetheless to make sure it's not a vasculitis or an infection. The mechanism of injury may be related to oxidation injury, oxidant injury, which is seen with chronic nitrofurantoin ingestion, direct cytotoxic effects, which can be aggravated by the oxidant injury. It may be related to deposition of phospholipids within the cells. This is one of the mechanisms thought related to amiodarone, and then immune-mediated injury, which is one of the mechanisms for drug-induced lupus. One of the papers that we had sent out initially, and both of them were a little bit laborious, I apologize, was the Matsuno paper. It's the shorter of the two, and it really sort of tries to delve into some of the mechanisms for this, and really breaks down cytotoxic and immune-mediated. And cytotoxic injury, it's looking at reactive oxygen species, the reduction in deactivation of metabolites, and impairment of alveolar response mechanisms. And then this release of cytokines. I know we've come to a state where we all love cytokines and cytokine storm. Direct injury to the pneumocytes or the alveolar capillary endothelium, again with this release of cytokines, and really sort of that suggestion of this is what causes capillary leak. There's an entity called chemotherapy lung, sort of a broad term given to many different chemos that can cause a DAD pattern. And this actually also works with radiation and oxygen and increased oxygen requirements. There's then an immune-mediated hypothesis where there's an immune-mediated response to a particular drug. We have antigenic determinants like the chemical structure of the drug. Genetic determinants, we may have polymorphisms in our genes that encode metabolization of these enzymes or metabolizing enzymes. Environmental factors, again, concurrent infections, pollution, stress, and then the nature of the drug itself, how much we're giving, how often, the route, are we giving it IV, PO? And some of these are a little bit more hypothesized, and I'm not going to pretend to go into this. I'll leave this to Andrew at a subsequent talk, but, really, they've looked at whether it's related to drug recognition, whether it's the concept of the hapten theory where the T cells bind it and present it to an antigen presenting cell. Is it the PI concept, which is a pharmacological interactions, or the danger model, which I'll be honest, I don't fully understand other than it causes danger. They're worried about, but again, these are all hypotheses for how these drug-induced lung diseases may start to initiate. But whatever happens, it leads to toxic effects that lead to epithelial and endothelial damage, which is then what we see on the clinical end of the spectrum. The diagnostic criteria are vague. We don't have any real great consistent criteria. It's again not recommended to give a diagnostic re-challenge for someone that you think has had interstitial lung disease related to a drug, and sort of using our histories and our physicals is the best way to guide us. There's no single diagnostic test or tissue biopsy that can definitively confirm the diagnosis. And it's, for chemotherapies, it's estimated that 10 to 20% of patients will develop some respiratory symptom related to their treatment. It's then incumbent upon us and their oncologists and their primary doctors to determine whether that limitation is so great that they need to stop the drug, or the benefit is still more important and they should be treated through it. Again, another classification of drug-induced interstitial lung diseases and sort of broken down by medications. There are chemotherapies that can cause cytotoxic effects, chemotherapies that can cause non-cytotoxic effects. There's antibiotics, and again, amphotericin, nitrofurantoin, daptomycin, like we spoke about earlier, anti-inflammatories, NSAIDs, aspirin, things like that. There's cardiovascular medicines. Another common one that we'll see is amio. Amio is probably the cardiac med that's tested the most. And then obviously things like heroin, cocaine, aspirated oil, mineral oil, things like that can all cause problems with the lungs. And then, things like blood products, the lymphangiogram, if someone gets done, they use an thiodized oil, which can cause, again, pulmonary edema. So whether it's direct pulmonary injury or capillary leak or increased cardiogenic or non-cardiogenic pulmonary edema, these are things that we all end up having to deal with. So part of what the Murray and Nadell chapter delves into is chemotherapy agents. It spends a lot of time looking at all of these different medicines and breaking them down into ones that are antibiotic derived, like bleomycin and mitomycin, alkylating agents, antimetabolites like methotrexate, Ara-C, gemcitabine, podophylotoxins, and then targeted therapies like monoclonal antibodies, tyrosine kinase inhibitors, and immunomodulator agents, which can all cause interstitial lung disease. And it's interesting, we give monoclonal antibodies now for COVID. We probably don't give them to the same degree and same rapidity with which people get Rituxan or Avastin, bevacizumab for their malignancies. But theoretically, if we gave monoclonal antibodies for coronavirus over and over again, we'd probably at some point start to see some interstitial lung disease related to that. So we'll go to another question, question 3. A 47-year-old former smoker is seen for evaluation of mediastinal and hilar adenopathy. She was diagnosed with stage 3B malignant melanoma of the left hip approximately 6 months ago. In addition to resection, she has been treated with immune checkpoint inhibitor pembrolizumab. Approximately 3 months into her treatment, she presented with fatigue, weakness, and generalized aches. Imaging, including a chest CT scan, was performed. The chest CT scan showed new mediastinal and bilateral hilar adenopathy without any abnormal parenchymal findings. She underwent EBUS-guided bronchoscopy with sampling of these lymph nodes in figure 1 and 2. Which of the following best fits her presentation? And I'll give you guys a minute in case you want to answer. Otherwise, we'll keep going. So clearly, they're trying to get you to some type of sarcoid-like reaction, right? You're seeing mediastinal and hilar adenopathy. You're seeing a granuloma. And so, tuberculosis can cause granulomas. Histoplasmosis can cause granulomas. Probably not metastasis for melanoma because I'm not Dr. Esposito, but these don't look like malignant cells. And then an immune-related adverse event. And that's what the answer is going to be. Partly because of the chapter 1, but also because that we're starting to learn that these immune checkpoint inhibitors, particularly our PD-1 inhibitors and our PD-L1 inhibitors, can cause a lot of adverse effects in the lungs. And what's interesting, and we'll see this over a couple questions as we go forward, is that these drugs, nivolumab, pembrolizumab, that we're now using more frequently, they're getting increased indications for melanoma, increased indications for lung cancers of various types, both as first line as adjuvant therapy, have pulmonary side effects. And that's not mentioned in any of these articles or any of these chapters because it's new. And that sort of signifies the difficulty of drug-induced interstitial lung diseases, is that this keeps moving, right? This is a moving target that we have to keep on top of. And so again, just as they explain, the presentation of symmetric hilar and mediastinal adenopathy without parenchymal findings and a biopsy that shows non-necrotizing granulomas favors sarcoidosis over fungal and mycobacterial infections. Malignant cells are not present. sarcoidosis-like reactions have been reported in patients receiving immune checkpoint inhibitors. It's actually been seen enough that they've created a grading system with, grade 1 is where you may have radiologic evidence, but patients are asymptomatic or it's confined to a very limited portion of lung. Grade 2, patients that are symptomatic involving more than one lobe, where you'll give prednisone, usually 1 to 2 mg per kg with a slow taper. And then severe symptoms and life-threatening symptoms, grade 3 and 4. And this is really where it becomes important to stop in all of them, you should hold the immune checkpoint inhibitor. But grade 3 and 4 reactions are where you should not re-challenge them. And grade 1 and 2, then it becomes a discussion with the oncologist about whether or not this treatment is important in the long-term cancer therapy. Question 4, a 74-year-old former smoker developed a persistent cough, weight loss, and chest wall pain. His evaluation revealed a stage 4 adenocarcinoma of the lung with metastases to his ribs and liver. He was otherwise healthy without prior known chronic lung problems. He initially had a partial response to treatment with carboplatin and pemetrexed, but after 4 months, the cancer has seemed to progress. His treatment was changed to an anti-PD-1 therapy with nivolumab. He notes symptomatic improvement, and his imaging shows a partial response with a decrease in the size of his primary tumor 3 months into treatment. Soon after, he experiences increased coughing without sputum production, more dyspnea with his activities, and fatigue. He does not have fevers or new chest pain. His chest is cleared auscultation. His O2 stat is 91 on room air. Spirometry is normal. A chest radiograph does not show any acute changes. An RVP is negative, and a chest CT scan is ordered. What is the most likely explanation for his new onset coughing and dyspnea? So I'm not going to wait for an answer on this one because it's sort of in line with the last question. Tumor progression leading to airway obstruction seems unlikely, as his chest x-ray doesn't show any acute changes, and symptomatically he had been improving on therapy. An acute exacerbation of COPD, again, unlikely without sputum production or a change in his cough. Atypical pneumonias or drug-induced pneumonitis. And now you're seeing someone who went from a platinum-based therapy with carboplatin and pemetrexed to a PD-1-based therapy with nivolumab, which we know causes pneumonitis. And so, again, in the same way it can cause sarcoidal-like reactions, immune checkpoint inhibitions can also cause interstitial lung disease or pneumonitis. It's not the most common adverse event. These drugs are related to a lot of adverse events, most commonly skin, gastrointestinal, hepatic, and endocrine manifestations. They can also lead to renal manifestations, if I remember correctly, and then less commonly, but potentially serious pneumonitis has been recognized. And in some reports, you'll see 2 to 5%, some you'll see up to 7%. And the treatment of pneumonitis is sort of going to depend on the grade, as we saw previously, but treating symptomatic patients sort of rests on stopping the therapy and starting steroids. And then just more about PD-L1 inhibitors. So this is a paper that came out in January. It was published in Chest. It's from the Fleischner Society, who publishes a lot on different pulmonary manifestations, but they talk about immune checkpoint inhibitors and these targeting agents. And so, this is something that we see and something that we see pretty regularly. And immune checkpoint inhibitors are interesting or important because a lot of times it's given to people for lung cancer who already have some amount of underlying lung disease. And so it can sometimes be a little bit more difficult to parse out. But the Fleischner position paper is a good read and probably a little bit of a more easy read than some of the other articles I had given. Question 5, a 65-year-old man is undergoing treatment for advanced non-small cell lung cancer. He had initially received platinum-based chemotherapy several months prior, but had progression of disease involving the left lower lobe, mediastinal nodes, and liver. He has started on nivolumab, there you go again, a PD-1 inhibitor. 3 months into treatment, there has been significant regression in the mass, mediastinal adenopathy, and liver mets, but he developed gradual dyspnea on exertion and a new dry cough without hemoptysis. He denies fevers, chills, sweats, or chest pain. Vital signs are stable at rest with the exception of a respiratory rate of 18, but he appears dyspneic and he quickly desaturates to 83 on exercise oximetry. Lungs have scattered rhonchi and crackles. Cardiac exam is without murmurs and a regular rhythm, and there is no edema or pain in the extremities. White count is normal with a normal differential, normal chemistry, and LDH of 120, which is, I believe, normal. A representative CT image is shown, and what is the most likely diagnosis, right? And I'll let you guys sort of think of the answer, it's in line with everything else we've seen. But this is where, less importantly for your test and more important clinically, this is what we need to figure out, right? Our patients are not always this black and white, but in someone with lung cancer who's now getting worse, is it possible that they're having lymphangitic spread of disease? Absolutely. But everything else from his cancer seems to be getting better, right? His mediastinal adenopathy, the primary mass, and the liver mets. Is it possible that he has pneumocystis? This could absolutely be the case, but if his LDH is normal, maybe that's a little bit less likely. Is it possible that he has a PE? 100% possible, but in a CAT scan where they're giving you the lung windows and not the mediastinal windows, probably less likely. And then immune checkpoint inhibitor toxicity, right? So again, sort of as the previous two questions, you can see as I went through the key questions, most of the drug-induced lung disease questions are centered around this class of medications, the PD-1 and PD-L1 inhibitors, and probably the medication that you'll be tested on the most in your test, both on the in-service and in your actual boards, in addition to things like daptomycin, amiodarone, bleomycin, and minocycline. But these PD-1 and PD-L1 inhibitors are probably going to be the most tested. So really important to understand that they can cause pneumonitis. So again, the same thing, the patient has developed pneumonitis from immune checkpoint inhibitor therapy. And, here they say that the symptoms can be mild to severe and fatal, and toxicity may start as soon as 9 days and as late as 19 months later. And again, I think this is a story that's unfolding in front of us. Most patients, or not most, a third of patients are asymptomatic. CT chest is the imaging finding of choice, but the findings are going to be very nonspecific, and most commonly maybe an NSIP pattern. There may be an acute interstitial pneumonitis, maybe some ground glass opacities, but everything, right? And then the sarcoidal-like reactions we had seen initially. So the CAT scans can really be anything, and so not always the most helpful, and so it's something that you have to keep on your radar. And again, this just sort of goes into how they grade the toxicity in grade 1 through 4, with 4 being serious, life-threatening. And so question 6 will stray a little bit from immune checkpoint inhibitors. Is a 68-year-old woman evaluated for hypoxia. She has a history of non-ischemic cardiomyopathy with an EF of 25, status post ICD placement with severe diastolic dysfunction, AFib, hypertension, and hypothyroidism. She has fatigue and back pain and was found to have compression fractures as a likely etiology of her pain. However, she was also noted to be significantly hypoxic with an O2 sat of 84% when breathing ambient air. Review systems is positive for slowly progressive dyspnea and exertion. Medications include amiodarone, aspirin, Coreg, digoxin, furosemide, levothyroxine, lisinopril, lovastatin, spironolactone, and warfarin. Examination shows her to be short of breath at rest with a temperature of 98.7, a blood pressure of 98/51, a heart rate of 70, and a respiratory rate of 24. Jugular venous pressure is 10 centimeters above the angle of Louis, and a heart rate is irregularly irregular without rubs, murmurs, or gallops. Chest examination is notable for diffuse inspiratory crackles, bilaterally a 1+, bilateral lower extremity edema is noted. Her chest radiograph and representative images from her chest CT are shown. Which of the following factors puts the patient at risk of having developed amiodarone pulmonary toxicity? So I'll give you a minute to take a look and answer. But they could have also asked which medication is likely the cause of her lung disease, right? And that would be an easier first order question, and it'd be amiodarone, but here they give it to you, right? And this is something that we see regularly. We get a whole lot of heart failure patients who are in trouble pulmonary wise. And so whether it's heart failure, whether there's some secondary pulmonary issue, or whether it's medication related or infectious, is again something that we see commonly. So anyone want to take a stab?
I'm probably wrong. I think it's either the age or female sex. I'm going to say it's the age.
Right. So I think it's easy for us to probably look at this and say it's probably not the statin use. Her EF of 30% also doesn't play a part, but you're right. I think age is the correct answer. So the risk for pulmonary toxicity are believed to include age greater than 60, a daily dose greater than 400 milligrams per day, a high cumulative dose, and pre-existing lung disease. Amiodarone, which is a class 3 antiarrhythmic, is effective against atrial and ventricular dysrhythmias, but it does cause pulmonary toxicity, hepatic toxicity, and thyroid dysfunction. And so something that we have to be mindful of, and patients should be followed pulmonary function testing. Because the cumulative amiodarone dose appears to be an important determinant of toxicity, patients typically who have been on medications for longer than 6 to 12 months should get pulmonary function tested, and this is in the time frame where you'll probably see some complications or symptoms start to manifest. They say a little bit later that pathologically amiodarone toxicity may appear as interstitial pneumonitis, eosinophilic pneumonia, organizing pneumonia, pulmonary fibrosis, or less commonly as diffuse alveolar hemorrhage, pulmonary nodules, or pleural effusions. Really what they've told you is this could be anything pathologically. And so again, in your patients that are on amio that are having sort of new or worsening dyspnea without another cause, and this may be one where you have to go in and rule out other causes, it's worth considering amiodarone. Question 7, a 75-year-old woman who has lived her entire life in Ohio is admitted to the hospital with increasing shortness of breath. She has a long history of diabetes, congestive heart failure, and AFib. She has been taking warfarin and metformin for greater than 10 years and amiodarone for greater than 5 years. As part of her initial evaluation, a chest radiograph and CT scan of the chest are performed, and a pulmonary consultation is sought. In addition to its association with advanced age, the abnormality of her central airways shown on the chest radiograph in a representative image from her chest CT scan is most likely associated with which of the following? So anyone want to take a guess, one, at what we're seeing and what they're trying to point out, and then two, the answer?
They're describing she has very, it's hard to see on the slide, but very calcified and prominent central airways, like the trachea and the mainstem bronchi are heavily calcified.
Right, very good. So she has extensive calcifications of her main airways, right, her trachea and her mainstem bronchi. So the question then was, what does that? Does diabetes do that? Does amiodarone, which I said can do everything, do that? Is it related to maybe she's been exposed to histoplasma or anticoagulation? And unfortunately, this is one of the things that you just have to know, that this is related to chronic warfarin use. There are prominent calcifications of this patient's tracheobronchial tree, in addition to an association with advanced age and dialysis-dependent CKD. This abnormality is associated with warfarin use. So it's most commonly seen in older adults, and it has no pathophysiologic consequence and does not produce airflow obstruction. It does not require that warfarin be stopped. This is just something or you don't, so just tuck it away in the back of your brain somewhere, and maybe it'll help you. The last question that we'll go over is a 21-year-old man spontaneously awoke with acute onset breathlessness, pleuritic chest pain, and generalized bone pain. He was well the day before, experiencing some symptoms, and has no prior medical issues. He started smoking cigarettes 2 weeks ago. He is not sexually active and has no history of substance abuse. On arrival at the ED, he was in moderate respiratory distress with a respiratory rate of 42 and was hypoxemic with an O2 sat of 80%. A chest radiograph is shown. He deteriorated over the ensuing 12 hours with hypoxemic respiratory failure requiring intubation and ventilatory support. A repeated chest radiograph is shown. Because of his deterioration, the patient was empirically treated for influenza, CAP, and pneumocystis cerevisiae pneumonia. Rapid HIV and influenza A PCRs were negative. A diagnostic BAL was performed demonstrating 40% eosinophils. Which of the following best describes the clinical features associated with the likely underlying pulmonary disease? Anyone want to give this a guess? This is sort of like the first question that we had.
This is acute eosinophilic pneumonia, it looks like.
Right.
It's a first-time smoker, I guess. And this usually resolves pretty quickly. So I guess 2.
Right. Right. It's always nice to have the longest, most complex answer, but you're right. So they give us a BAL that shows 40% eosinophils, and we have someone that has acutely changed based on their clinical status, needing to be intubated, and their X-ray. So this is acute eosinophilic pneumonia, and it's thought to be an acute hypersensitivity reaction to a medication or an inhaled agent. In this case, it's the fact that he just started smoking, and so in contrast to chronic eosinophilic pneumonia, AEP has rapid onset and is associated with a rapid response to corticosteroids. So people don't need 9 months of steroids as part of their treatment. So the question then comes, what about pulmonary function? Is it important to do pulmonary function tests? And PFTs are important in the assessment of suspected DI-ILD, but like CAT scans, it lacks specificity. Your DLCOs will be low, and this may be low even before patients are symptomatic. And as they become symptomatic, you'll start to see some restriction. Changes in FBC correlate with clinical progression in patients with bleomycin-related interstitial lung disease. So this testing is important, but again, unfortunately, it can't clinch your disease. But in people where you start to see reduction in lung volumes or a reduction in DLCO, as you stop the medications, give them steroids, if that's what you decide, you can start to follow their PFTs and see if you have improvement. BAL and lung biopsy are also sort of discussed in both the textbook and some of the articles. It's again non-specific, but really important in exclusion of other things. So exclusion of opportunistic infections, exclusion of vasculitis. You may see a reactive type 2 pneumocyte hyperplasia. You may see some reversal of CD4, CD8 lymphocyte ratios. And in terms of biopsies, for this disease pattern itself, biopsies are probably less helpful because almost all histopathological patterns have been reported. And so you'll find something, but whether that will point you to your disease process or not, it is, again, based on whether you've thought of it. So people have then looked at circulating biomarkers, and the 3 biomarkers that are sort of mentioned in the text are KL6, SPA and SPD, and ADAM8. KL6 is a mucin-like glycoprotein secreted by your alveolar pneumocytes in response to damage and regeneration. It's been found in about 53% of DI-ILD patients in some studies, and often correlates with DAD pattern pathology and more extensive lung involvement. In some of these studies that have followed patients, the KL6 levels over time correspond to clinical course. So as the levels go up, people get worse. If the levels go down, then people seem to get better. Surfactant proteins SPA and SPD have been reported as specific markers in pulmonary fibrosis and also seen in this DI-ILD population. And then ADAM8 concentrations have been increased in drug-induced eosinophilic lung diseases and actually go up as the eosinophilic lung disease gets worse. But again, none of these are things I think clinically are being followed. Of them, the KL6 may be the one that shows up sort of as ancillary information in a test question, I would think, because it seems to have the most research behind it. But again, not something that we're often checking clinically. Then comes this question of prevention. Should a screening pulmonary function test be done? It is commonly done in patients about to begin or already taking drugs with pulmonary toxicities. Obviously we don't do PFTs in everyone that starts amiodarone in the hospital, but almost every patient that starts bleomycin is sent for pulmonary function testing, and part of that is that's the culture in the oncology world. The NCCN clinical guidelines for oncologies recommend PFTs as part of the essential workup prior to initiation of bleomycin containing chemotherapy for potential curative treatment of Hodgkin's lymphoma. And that's where sometimes we'll have discussions with the oncologist if they feel that bleomycin will help cure their patients, and there's minimal risk for the severity of lung disease, then maybe it's more important to give it to them, even if their DLCO prior to treatment's a little bit low. Some oncologists or hematologists will admittedly be hesitant and not do it. But again, you have to think about whether or not they have alternative therapy. And unfortunately, right now, as far as I understand, bleomycin is the best part of treatment for cure of Hodgkin's lymphoma. So again, that's a risk-benefit discussion. But it's even though in pulmonary literature it's not there as shown to be beneficial, because the truth is we don't know. it is in the NCCN clinical guidelines, and so something that will not stop. The treatment for this disease is pretty easy. It's, if you can figure it out, stop the medication, and if they're not getting better with that alone, you give them steroids. But again, even the look at steroids is not proven. You know, how much steroids, what dose of steroids, how long. Most people will get 1 to 2 mg per kg and then tapered over a few months. But again, it depends on what the disease pattern is, right? That's not necessary if someone has acute eosinophilic pneumonia, but maybe more important if they have an organizing pneumonia or something else. So really the conclusion for this talk, and I apologize that it's been a little bit long and laborious, is that drugs can cause problems in the lungs. You have to be alert and keep this on your differential. Drugs can be associated with more than one histological pattern. So each drug may have multiple different manifestations. And we are constantly finding new drugs which cause new pulmonary problems. And this is a diagnosis of exclusion, so you have to think about it. And that's all I got. Any questions?
Samir, that was really great. Thank you. I don't know if you mentioned this because I got a patient call while I was listening to your talk, but the website Pneumotox?
I did, and I actually credited you as well.
Oh, okay.
Because you're the first one that told me about it, and it's the best thing we have because it's most up to date in terms of sort of following case reports and things that are out there. And so I think it's a great resource.
Thanks, Samir. And it definitely comes out clinically. Definitely amio, the bleo, between oncology and cardiology, it definitely comes up a lot. It's always a discussion. It's never straightforward. I mean, not typically unless they're really sick.
Yes.
Thank you, Samir. That was really excellent. Excellent review and very, very clearly presented.
Thank you.
All right.
All right, guys. Have a good night.
Thank you so much.
Thank you, Samir.
All right.
All right. Have a good one. Bye.